idea. I am so smart, suddenly it just appeared. There's a light above my head, sometimes white and sometimes red. My ideas make it glow, and very soon the rest of the world will know. I just came up with a really bright idea. I am so smart, suddenly it just appeared. I just came up with another bright idea. I am so smart, suddenly it just appeared. There's a light above my head, sometimes white and sometimes red. My ideas make it glow. And hello, hello. Good morning, everyone. Well, if you're on the West Coast, I'm going to say good morning to you. If you are on the East Coast, good afternoon. And wherever you are, hello, hello. Let us know in the chat how you all are doing. Thank you again for joining us for our third week of our YT course. So before we get started, we do have a lot of our viewers that are requesting some more information on how to get additional coding help. So I just wanted to let everyone know, I wanted to take this opportunity just to let you all know that you can visit us at amcicoding.com. So again, that's www.amcicoding.com. And all you do is when you get to this page here, you click on courses. And we do offer a couple courses. What we would recommend is either the lecture series or the fast track course. And so you click on courses, you have a drop down menu here, and then go down to lecture and fast track courses. Click on that. And then when you click on that, you'll get to this page here, and you can enroll in either your lecture series or the fast track course, okay? And these are per month subscriptions. All right, so hopefully that's helpful. And with this, you get all of AMCI's lectures. I mean, they are great. This is what these are the lectures that I watched to pass my CPC exam. And let me tell you, they are superb, okay? You get to spend that time with Mrs.Jay going through all the guidelines in detail, and you get some really good scenario practice, okay? All right, and let us know in the chat if you have any additional questions, and we have a great team standing by to answer your questions. All right, moving right along, we are on week 3. Yes, today we will be discussing the respiratory section. So I hope you're ready. Have your CPT manuals next to you. And I am ready to get started. I hope you all are. And I have to introduce our wonderful team. I'm Mrs. Tracy. I am the instructional team and intern director here at AMCI. I'm a CPC and an AMCI approved instructor. And I want to introduce our amazing team. So go ahead and say hi to our wonderful instructors that'll be in the chat with you all. We have Miss Sarah, Miss Tiffany, Miss Mia, Miss Jody, Miss Angela. So go ahead and say hello to them in the chat. And I want to introduce you to who will be helping us today with our presentation. Miss Rochelle, she is our partnership and marketing director. She is a CPC and also AMCI approved instructor. Hi, Miss Rochelle, how are you?
Hello, Miss Tracy. I'm doing great. How are you? And hello, coders. Welcome back. This is our week 3 for YT class. Can you believe it? Oh my gosh, I am just so excited to be here today, Miss Tracy. And I know we're bringing in some great stuff tonight. We have a lot to learn. So I'm ready to get started, Miss Tracy. Thank you so much.
Yes, I am so excited to get started for week 3 here. And we've been having a great time so far in this YT course. So again, I want to thank you all for continuing to come back. And last and certainly never least, our wonderful Mrs.Jay. She is BA, I have to shout it all out, CCS, so proud of that, CPCI, CPC, and she is an AMCI and an AAPC approved instructor. Hello, Mrs. J. Good afternoon. How are you?
Hello, hello, hello. Good afternoon to you, Mrs. Tracy. Good afternoon to you, Ms. Rochelle. And good afternoon to you, AMCI team. Oh, you know what? I didn't forget about you, coders. Good afternoon. Thank you so much, Mrs. Tracy, for that introduction. It is beautiful. I am coming live to you from sunny North Carolina. And Mrs. Tracy, will you please do me a favor and send me over that screen so I can get started?
Absolutely, Mrs. J.
Thank you, thank you. All right, coders, I got a question for you. Well, no, I don't. I don't have a question for you. Guess what? Do you want to win an AMCI lecture series that Mrs. Tracy was talking to you about? If you do, this is how you do it. We're going to have a drawing, and this is how you enter. Comment on this video below in the comment section, not in the chat, in the comment section. Tell us what you've learned in today's presentation. And then we're going to place a link in the chat, in the live chat, after this lecture for you to go ahead and sign up for the drawing. We will announce the winner next week. That's week 4. So if you want an AMCI lecture series, you'll get to see all of the AMCI lectures, not just integumentary through nervous system. You're going to get our entire ICD-10-CM collection. You're going to get our entire E&M section. And you know what? You're going to get the full shebang. So go ahead and make sure that you comment in the comment section what you've learned and complete the link, sign up, and you'll win. I know someone that's lucky today will win. All right, so let's make sure that this chat is working. I have a question for you, and you know pretty much the same question every week, but I want to know, coders, how confident are you with respiratory system guidelines? If you're very confident, write it. If you're somewhat confident, go ahead and write that. If you're barely confident, it's okay. Or if it's something else, go ahead and write that. I need to know how to instruct you. Yes, we are tailoring our presentation to you. So if everybody here is very confident, we're going to level it up a little bit. We're gonna definitely have something for everyone. So just want to know what you know. How confident are you with the respiratory system guidelines? Are you very confident, somewhat confident, or barely confident? Or if it's something else, go ahead and write it in the chat. And while you're doing that, I'm going to go over the class rules. This is an advanced class. Remember, we've said this each week, so I'm going to quickly go over these rules. And don't forget, the pace will be accelerated. If you are currently in a comprehensive course already, this class may be for you. However, if you're a new coder, you might need some more instruction. And this playback will remain at least for the remaining of this year. So you don't have to rush. If you want to watch the playback, you have a little time. And the homework will be available in the comments section for 24 hours. Don't forget, you should already have some experience with CPT guidelines, and class will move at a faster pace. Goals for today, we're going to review guidelines for the respiratory section of your CPT manual. Goal number 2, of course, we're going to provide scenarios to further clarify the more complex coding guidelines. Goal number 3, we're going to give you some CPT documentation tips. And 4, we will help you demonstrate the importance of forensic reading. If you don't know, we practice forensic reading at AMCI, and that is reading very carefully to get the most accurate code. And finally, do I repeat myself? Yes, I do. Class will move at a faster pace than usual, and coders, make sure that if you see someone in the chat saying, hey, the pace is a little fast, let them know that this is an advanced class. And the course outline. Week 1, we reviewed integumentary system. Week 2, that was last week, we reviewed the musculoskeletal section. So the playbacks for each of these weeks are on the AMCI channel. So just go ahead and search and you'll find it. In fact, I think we have a folder. So go find the YT 2019 folder and you'll see these courses, these classes. Week 3, and that's today, we're going to be discussing respiratory system. Week 4, cardiovascular. Week 5, digestive. Week 6, urinary male and female. Week 7, nervous eye ear. Week 8, radiology, anesthesia. Week 9, pathology. Week 10, medicine. And we will not cover evaluation and management or ICD-10-CM or PCS. And finally, don't forget, class will move at a faster pace than usual, and this is an advanced class. And another thing you need to note, if you have a question, go ahead and type your question in the chat box. Keep in mind the instructor speaking is not able to see your question. We have it set up so that we can keep the information continuous. So we want to continually teach, and we're going to allow the AMCI instructors to answer your questions. So you'll see them because they have an AMCI, I would say, logo next to their name, and it should read AMCI instructor, Mrs.Jay, Miss Rochelle, Mrs. Tracy, Miss Mia, Miss Sarah, Miss Jody, Miss Angela. You'll know, you get the picture. Okay, so they are standing by to answer your questions as you provide them. And they're also there to encourage you. So say hi to them. And finally, before we get started, I just want to read the copyright. CPT is copyright of the 2000 AMA. All rights are reserved. Fee schedules, relative value units, and conversion factors or related components are not assigned by the AMA, and they are not a part of CPT. And the AMA is not recommending their use. The AMA does not directly or indirectly practice medicine or dispense medical services. The AMA assumes no liability for data contained or not contained herein. CPC is a registered trademark of the AAPC. AAPC content found within this presentation is copyright of AAPC. Keyword concept, FTR, Chun, AMCI Fab 7, Flip Tap are all trademarks of AMCI. Okay, let's get down to business. And before we get started, we're going to go over some general coding guidelines, and you need to know them because these general coding guidelines apply to all of the surgical procedures within CPT, and we are talking about respiratory system today. So it's important that you remember that all of those respiratory system codes have other items bundled into it. Those respiratory system codes are surgical codes, and they have a surgical package. And within that package, they have 6 things. They've got evaluation and management visits on the day before or the day of surgery. Local infiltration or local anesthesia is bundled in that code, and immediate post-operative care, the writing of the orders, evaluating the patient in the post-anesthesia recovery, and typical post-operative follow-up care. All of those services are included in the surgery codes within the surgery section, specifically in the radiology section in the radiology surgical codes. And another thing that I want to bring to your attention is the general guideline on separate procedure. You're going to see this separate procedure play out today. Yes, remember, a separate procedure is a code with the words separate procedure in parentheses after the code language, and it means that this code should be coded by itself. It also means that if it is if it sorry about that. It means that this code should be coded by itself, and this code can be coded with another procedure as long as it's not related. Okay, so the only time you can code it with another procedure, it is not related to that procedure. And if you do code it with another procedure, you need to use modifier 59. Okay, so let's talk about some more guidelines. You got to trust those guidelines because the guidelines are going to direct you to the correct answer. You've got 3 types of guidelines, and you've got 3 levels or levels of hierarchy. So you've got parenthetical guidelines. These are the guidelines within the parentheses. See, like this. And these are your highest ranking guidelines. They take precedence over all guidelines. Second are your code series or chapter guidelines. And you'll often find them underneath the blue bold and before your code series. Your third type of guidelines are general coding guidelines. You can find them in the green pages, just like what we've seen, the surgery guidelines. And if there are no guidelines, you trust your keywords. Your keywords will drive you to the answer. Now let's talk about the respiratory system. So here is my brief anatomy of respiratory system coding. When you're coding for the respiratory system, you need to know the anatomy of the respiratory system. You've got an upper respiratory system and you have a lower. And see this pink line that I've drawn? The pink line represents upper and lower respiratory system. The upper respiratory system is outside of the chest cavity and the lower respiratory system is within the chest cavity. And that's pretty much all. I think we've gone through anatomy, or you should have gone through anatomy and physiology to go over the different parts of the upper and lower respiratory system. So I won't do that. I don't want to be redundant. And also a part of respiratory system coding are the paranasals. We're going to go back and just make sure that you know that your paranasals are bilateral. You've got 2 pair of paranasals. You've got frontal, ethmoidal, sphenoidal, and maxillary sinuses. And finally, the lungs. Make sure that you can distinguish the right from the left, the right lung from the left lung. The right lung have 3 lobes and the left have 2. Make sure that you know that. And here's another thing that I'd like to show you. When you see the electronic CPT, we place annotations in them. So just want to let you know that these are my annotations. The bundle, when you see this little squiggly line, that's a bundle. That means that other items are bundled within it. When you see this plus sign, this means code additionally or code separately. When you see this X right here, that means do not code. It's a general do not code. And when you see the circle with the line that represents do not, it's a specific do not code, such as do not code modifier 62. And this asterisk that you see, they often go next to parenthetical guidelines. It's a do not code. If you have a parenthetical guideline and it's telling you to do not code something, I put 2 asterisks next to it so that I see it. And finally, when you see these two eyeballs, this means you've got a lot of guideline, so go read the guidelines. And often I'll put the page number too. So the guideline of today is separate procedure. Don't forget that separate procedures are procedures that can be coded by itself, and they should be normally. However, they can be coded with other procedures as long as they're not related. And if you do code it with another procedure, then you be sure to append modifier 59. This is another look at the guidelines, and the guidelines are found on page 72 of your CPT manual. So if you want to go ahead and read it for yourself or make some notations for clarification, go ahead and do it. And while you're making note of it, I think it's time for a scenario. Let's practice coding our first scenario. Okay. All right. A 40-year-old male, status post, esophagectomy, and not able to speak, presents for a laryngeal speech prosthesis. Insertion. The patient is prepped and draped in sterile fashion, then placed in supine position. After induction of anesthesia, a lateral incision on the neck just above the trachea and esophagus is made. After the tracheostomy, the doctor creates a fistula. The Blom-Singer speech prosthesis is then placed in the opening. The incisions are closed with sutures. Which procedure codes best describe this encounter? Okay, coders, what did Mrs. J forget to do? If you said read those answers first, outstanding. So please forgive me and let me go ahead and read these answers. A, 31611, 31600 with a 59 modifier. B, 31600. C, 31611, and D, 31612. Okay, coders, you have a minute and a half. Okay, so you all notice we have a new feature, this pink bar at the bottom. When that pink bar is finished, that means time is up. And yes, I may have stopped it, so I gave you a little extra time, but you know what I need to do? I need to fix something because I had a slide that was not showing. So I need to make sure that it is so that we can, there you go. All right, so I want to go ahead and show you the answer. Hopefully it's working. All right, now you should see my screen. All right, so the answer, what is the answer? If you said C, outstanding, here's why. All right, so our keywords. 40-year-old male, status post, esophagectomy, not able to speak, laryngeal speech prosthesis insertion. That's why he's there. A lateral incision and a tracheostomy. Doctor creates a fistula. Brahms Singer speech prosthesis placed in the opening. Incisions. Okay, those are our key words. And looking at these answers, coder, is there anything that you can eliminate on site based upon some guideline instruction that you just received? If you said A, you are correct, and here's why. If you look at code 31600, this is the code for tracheostomy, but it is a separate procedure. And remember, I said separate procedures are coded separately. And if you look at A, it is coded with another procedure. And the only time that you can code it with another procedure is when it's not related. And if you're looking at this code series, 31611 and 31600, they're in the same family or somewhere around each other, same body area, same something. So on site, I can eliminate it. But let's read on. That's just a little tip I'm giving you whenever you are, for those of you that are taking your exams. All right, so we know 31600 is a separate procedure. This is the code for tracheostomy. And a tracheostomy was carried out, but also so was a fistula. So these two are related. We are not going to code for each, and remember that language, and this is the language below telling you how to use the separate procedure guideline, and A is eliminated on site for me. And also, so is B, because B, I'm going to go back, is coding for only the tracheostomy. It is not coding for the fistula. So we're going to get rid of B. Now let's turn our attention to 31611, and it's coming up green. That means that it's a correct code. And the reason why, this is the code for construction of tracheoesophageal fistula and subsequent insertion of a laryngeal speech prosthesis. And then they give you an example, Blom Singer prosthesis. Well, how do you like that? A Blom Singer speech prosthesis was carried out. Now let's look at why 31612 is incorrect. It's incorrect because this is a tracheal puncture, percutaneous with transtracheal aspiration and or injection. Did we have a puncture? Is this what happened? No, we did not have, our patient is not here for a puncture. Our patient is here for a tracheostomy and insertion of that prosthesis. So D is eliminated and C is our answer. All right, coders, if you said C, outstanding. If you learned something, that is priceless. All right, let's see what's up next. And I think endoscopy of the sinus with Mrs. Tracy.
That is right. Great scenario. Thank you so much, Mrs. J. Great discussion. And yes, we are moving on. We're going to talk a little bit about the endoscopy of the sinuses here. Okay, so a nasal endoscopy is a procedure that looks at the nasal and sinus passages. It is done with an endoscope, as you see right here in the illustration. The endoscope is a thin, flexible tube with a tiny camera and a light that is attached to it. Okay, and typically an ear, nose, and throat doctor will often do this procedure in his or her office. Okay, so this is typically done in an otolaryngologist office. Okay, so let's talk about some guidelines here. All right, so there are some things that are bundled, there's some things to watch for, and there's some things that you may need to code in addition to these endoscopies. So let's go ahead and look at this. First of all, the surgical sinus endoscopy includes the sinusotomy, so that's basically cutting into the sinus there, and it includes the diagnostic endoscopy. So that is bundled. Okay, notice the little bundled symbol there. Code range 31295 to 31298 describe the dilation of the sinus ostia by displacement of tissue, any method, and this includes the fluoroscopy if it's performed. Okay, so that is also bundled. The stereotactic computer assisted navigation may also be if that is performed, the stereotactic computer assisted navigation, you would report that with code 61762 or 61782. Okay. All right. And most of these codes are unilateral. If perhaps you're dealing with a bilateral, just make sure that you need to append that modifier 50. And codes 31231 and 31235 are for diagnostic evaluation, referred to employing a nasal or a sinus endoscope to inspect the interior of the nasal cavity and the middle and superior meatus, the turbinates, and the sphenoethmoid recess. Okay, so keep that in mind. Okay, what this includes. Okay, again, this includes the inspection of the interior, the endoscope to inspect the interior of the nasal cavity and the middle and superior meatus, the turbinates, and the sphenoethmoid recess. Okay, and we'll be revisiting that later. Anytime a diagnostic evaluation is performed on all these all these areas would be inspected and a separate code is not reported. So you don't report a separate code. That is all inclusive, okay? Now, say that all of those were not inspected, then you're gonna have to append some modifiers, okay? So when all of those elements that I just described are not fully examined, okay? This is something to watch out for. When they're not fully examined, then you're gonna append a modifier 52. Okay, if there is no repeat examination that's planned. Now, if a repeat examination is planned, then you're going to append a modifier 53. So again, if everything that I mentioned up there is not examined and there's no examination planned, you append modifier 52. However, if it's not all examined and there is some examination that is planned, future examination, then you append modifier 53. It's very important to remember those guidelines, okay? Alrighty, let's move right along. And then the codes 31231 through 31297 are used to report endoscopic sinus surgery. Again, pretty much everything that I told you before. Just watch out for that modifier 50. So the guidelines that I want you to remember here is to watch for the bilateral and unilateral language. Okay, make sure that you see what the code descriptor is telling you. Scopes again include the inspection of the interior nasal cavity, the middle and superior meatus, the turbinates, the sphenoethmoid recess, sinusotomy, and fluoroscopy. Okay, we do not code those separate. We use a modifier if all of those are not examined. Okay, so we're ready to put this into play with a scenario. I have a good one for you. Okay, so here is actually, okay, for some reason my bar on this slide is not working, so it came up prematurely, but that's okay. We'll work with that. We have our answers here: A, 31231, modifier 53, B, 31276, C, 31231, modifier 50, or D, 31231, modifier 52. Donna had a bilateral nasal/sinus endoscopy performed. An endoscope was inserted through the nose. The physician inspected the nasal cavity, middle and superior meatus, and turbinates. The sphenoethmoid recess was not inspected due to anatomical deformities. In the near future, an open procedure is planned involving tissue removal from the frontal sinus to view the space. All right, I will give you 1.5 minutes and your time begins now. All right. Get your answers in the chat. Let me know how you did. All right. Okay, so let's go ahead and see what's going on here. So first of all, our answer is going to be A. Okay, and let's find out why. Okay, so my keywords, I have bilateral, nasal sinus endoscopy. We have an endoscope that's inserted through the nose. Physician
Hello, Miss
inspected.
Tracy. Knock,
Oh,
knock. I'm
sorry.
sorry to budge in, but it looks like your screen might have been paused.
Okay, yeah, it was. Sorry about that. Okay, give me 1 second. Thank you, Miss Rochelle.
You're welcome.
Okay, all right, so, okay, can you see it now? Is it moving?
Yes, it is.
Okay.
It is.
Thank you, Miss Rochelle, my lifesaver. Okay, our answer is going to be A, and again, let's find out why. So here's my keywords. I have bilateral nasal sinus endoscopy. We have an endoscope inserted through the nose. Physician inspected nasal cavity. We have middle and superior meatus and turbinates. And if we look at the illustration over here, kind of I just boxed around what was done here, what was looked at. And remember what I said before? It says this when we were reading those guidelines, the sphenoethmoid recess says was not inspected. And that is going to be part of that endoscopy. So we'll talk about that in a second. But let's go ahead and look at 31276. And this is for nasal or sinus endoscopy. I like that keyword. But this says with frontal sinus exploration, and that didn't happen. That says that that's going to take place in the future. So that is going to be incorrect. So we're going to get rid of that. Okay, and the next one we have 31231. That's for nasal endoscopy. diagnostic, unilateral or bilateral. So pay attention to that code language there, okay? Unilateral or bilateral, meaning when it says that, it does say we have a bilateral here, but in our code language, it includes unilateral or bilateral. So that means there is no need for a modifier 50, okay? So we can go ahead and get rid of answer C, okay? Then it comes down to either putting the modifier 53 or 52. So it says the ethmoid was, oops, sorry. Actually, I got ahead of myself here. Okay, I'm going to just pull up the guideline here. So I got rid of D. Our answer is A. And remember, it comes down to that modifier. So if there's an examination that is planned in the future, which it says here there is a repeat examination near future, there's going to be an open procedure that's planned. So when we have an examination that is planned, then we would pen modifier 53, okay? So that would mean modifier 52 would be incorrect, so we'll get rid of D, and that makes A the correct answer, okay? Let me just go ahead and highlight that for you guys. Alrighty, so talk to us in the chat. Let us know how you did. And if we're ready, I have another scenario for you. Okay. All right, moving right along, here's our answers. We have A, 31020, 65110, modifier 51, 15120, modifier 51, B, 31225, C, 31230, 65110, modifier 51, 15120, modifier 51, or D, 31230, 15120, modifier 51. A 58-year-old entrepreneur with a history of severe chronic sinusitis of the left maxillary sinus, a left maxillary malignant tumor the size of a quarter, and diseased tissue of the left orbit. Presents to the OR for removal of the maxillary sinuses. The patient is prepped and draped in sterile fashion. After induction of anesthesia via frontal approach, a Weber-Ferguson incision is made, which includes the upper eyelid. The left maxilla is fractured. The skin flap is elevated. The tumor and surrounding tissue are removed from the maxilla. The surgeon turns his attention to remove the diseased left orbital tissue. Advancing through the upper eyelid incision, after removing nerves and vessels, the diseased contents from the left orbit are removed. The surgeon covers the defect with a previously harvested split-thickness skin autograft. Drains are applied and the incisions are closed in layers. Which procedure codes best describe this encounter? And you have a minute and a half. Good luck, coders, and your time begins now. Okay. Sorry, I think my screen is malfunctioning over here, but we revealed the answer there. I apologize. The answer is going to be D. Okay, so let's go ahead and find out why. I think my screen was froze on that bar, so I don't know if it's interacting with my screen on this side, but I apologize for that. Okay, so looking at my answers, I see that C and D have the same first listed code. I noticed that B only has one single code there, and then we're dealing with some 65,000 series codes and some codes from the 10,000 series, so we have some intake there as well. Okay, so let's see what's going on here. All right, my keywords first, we have a 58-year-old, has a history of severe chronic sinusitis, left maxillary sinus, left maxillary malignant tumor. He has diseased tissue of the left orbit, removal of the maxillary sinuses via frontal approach, Weber-Ferguson incision. We have upper eyelid. The left maxilla is fractured. We have a skin flap. The diseased left orbital tissues removed, and as well as the nerves and vessels and the diseased contents from the left orbit. Okay, those are also removed. And we have a harvested split thickness skin autograft. Okay, so let's go ahead and look at 31020. That's right there in answer A, and that is for a sinusotomy. So that is cutting into the sinuses, maxillary, intranasal. So I don't see anything about intranasal, and also we are removing, we're not just cutting into the sinus here. It does say maxillary, however, it is removing that maxilla, okay? So this 31020, that is the wrong procedure, okay? And the wrong approach. All right, so we are going to get rid of A. Okay, we're going to move on. We're going to look at 31225. I like that maxillectomy because that's what happened here. The maxilla was removed. So we did have a removal of the maxilla there, but this says without orbital exoneration. And basically this right here, if you don't know, and you might want to just jot it down next to this code, but that is removal of this orbital exoneration means the eyeballs removed and the tissue, okay? So you might just want to jot that down there. And if we look at our scenario, it says that it is removed. If you read here, the surgeon turns his attention to remove the diseased left orbital tissue, the advancing through the upper eyelid incision. After removing nerves and vessels, the diseased contents from the left orbit are removed. Okay, so this 31225, we need a little bit more. We have a little bit of what happened here, but we need a little bit. We need to go a little bit further. So 31225 is not going to cut it, so we'll get rid of answer B. And if you go down to 31230, which is our first listed code in both C and D, that is for the maxillectomy with orbital exoneration, okay? And that's what we're looking for, okay? So we know that that's our first listed code there. And it tells us for orbital exoneration only, you're going to see 65110. So that just the orbital exoneration, we had more to that. We have to also code for the maxillectomy. So we're not going to be coding this 65110 because we didn't just have the removal of the eyeball and tissue. Okay, so we're going to get rid of that code, which is in answer C. Okay, and so what we have left to check is going to be that intake code. So 15120, and that tells us in the next parenthetical guideline below 31230, for skin grafts, you want to see 15120. Okay, and that is for, let's look that up, that's for the split thickness autograft that was performed, okay, of the face, and this is where we're at, the face, okay, that's the right area, and that's, I like that code, that's for our autograft, and that means D is the correct answer, okay? All right, type in the chat. Let us know how you did. Thank you all for participating. We really appreciate that. And I'm going to go ahead and talk with you all in the chat. So if you have any questions, that's where I'll be. And I'm going to hand you on over to Miss Rochelle.
All right. Thank you so much, Miss Tracy. That was a great instruction and wonderful scenarios too. I really enjoyed that. And I know these coders enjoy those scenarios as well. I do have some more, but first, we are going to continue on and talk about scopes. scopes, but this time we are going to be talking about laryngoscope. Okay, so everybody ready? All right, so basically, a laryngoscope, as we know, is used to perform an endoscopy of the tongue base, the larynx, and hypopharynx. And this picture here, as you can see, it shows a scope that is viewing the area almost to the trachea. So in general, it is a medical procedure that is used to obtain a view of an area of the region mentioned, you know, the tongue base, larynx, and hypopharynx. And for example, of these are like vocal folds and glottis. Okay. I I hope I did that word correct there. But yeah, so that's a laryngoscope. But as a coder, we do need to know how to code them. So we're going to have to go and look at our guidelines. So we're talking about endoscope again, but this time in the area of trachea and bronchi. So that would be what we're going to be focusing on. So in here, when you're reading our guidelines, we have to pay attention to the bundled ones. So just like we went over earlier with your endoscopy, there are also things that are bundled into your laryngoscopy. So for endoscopic procedures, report appropriate endoscopy for each anatomic site examined. Laryngoscopy in particular includes the examination of the tongue base, the larynx, and hypopharynx. The anatomic structures examined with this procedure include midline, or the single anatomic sites, and paired structures. So I mentioned the paired structures. That is going to be what you're going to be looking at. Okay, because these paired structures include true vocal cords, arytenoids, false vocal cords, ventricles, pyriform sinuses, and arioepiglottic folds. And these are actually going to be coded as pair. Unless it's going to be coded from one side only, then you will have to code it as unilateral. Okay, and that guideline is telling us here over here. Okay, so for the purposes of reporting therapeutic interventions, all paired structures contained within one side of the larynx pharynx are considered unilateral. So if you are only coding for one side, then you will have to code it as unilateral, because this are actually come, anatomically comes in pairs. Okay, so these vocal cords, arytenoids, false vocal cords, ventricles, pyriform sinuses, and arioepiglottic folds. All right, and that's it. That's really the things that you have to pay attention to when you're coding this laryngoscopy. So what do you say? Let's get to coding. Let's put this into practice. I have a scenario there. Oops, I missed one more notation in case you want to go ahead and screenshot this. I think I have everything in here now. And then we're going to go ahead. Oh, there's one more. Sorry about that. There's one more. Sorry about that. So I have to say about this too. Another thing is that if we're using operating microscope, telescope, or both, use the applicable code only once per operative session. You're going to have to code that in addition to your procedure. And finally, that's it as far as the guideline. Okay, so I'll give you a moment, and then we're going to go ahead and let's try this scenario out. So I'm going to read this to you. We have A, 31511 with modifier 50, B, 31511, C, 31530. For D, you have 31530 with modifier 50. And here's your scenario. A 28-year-old Melanie has a history of laryngitis, arrives to the ENT clinic for a laryngoscopy. With the aid of a mirror for better viewing, the physician removes a foreign body from the left-sided pairs of the patient's vocal cords. What are the procedure codes for this encounter? And I think you all know the drill now. I'll give you a minute and a half, and you will see this bar over here. As soon as it ends at the end, then that means it's time. So go ahead and let's get coding, coders. Okay, coders, do you have your answers ready? I apologize because I don't think that timer thing is working. So you see, we tried to have some cool stuff over here, but we're gonna make that work. But I think you should have enough time to get your answers in. So if you have, go ahead and put them in the chats, and then we're gonna go over the scenario with you guys. So the answer for this is going to be B, and let's find out why. So we have our keywords here. We have history of laryngitis, laryngoscopy, mirror removes a foreign body, the left-sided pairs, vocal cords. So if we're going to take a look at the code descriptions we're given here in your answer choices, so basically we have two families here that we are looking at. So we have that 31505 family where you can code 31511. That is laryngoscopy, indirect. And remember, indirect means that this is with using with mirrors, okay? So we're gonna have to look back in our scenario and find out if this physician used a mirror. And indeed, they did use that mirror as an aid for viewing. So we're going to have to be coding this from this family. So we're going to look at that 31511 with removal of foreign body, exactly what happened. So we like this so far. So I'm going to have my star over there, but I do have to take a look at the rest of my codes to see if I'm not missing anything. So 31530, that's laryngoscopy again, but this one is direct, operative with foreign body removal. Again, that direct would indicate that this one did not use mirror, or the physician did not use mirror to in this procedure. So we already know, as far as our keywords go, that the physician did use the mirror. So anything that comes from here, that would mean C and D is going to be wrong. Okay. Now from here on, A and B, the only difference is that modifier 50 for bilateral. Now remember our guideline, we talk about the paired structures, and one of those paired structures are actually the true vocal cords, which is the location of our procedure here. And we know that is that comes in pairs. However, in our scenario there, it only mentioned the left side pair. So what that means is that we're coding this as unilateral. So we're gonna have to eliminate A because we do not need a modifier 50. All we need is that 31511. All right. Left-sided pair. So sorry about that. I think I confused you on that one. So this is the left-sided pair. So we do not need to indicate the modifier 50 anymore. So your code is 31511. So let me know if you have questions for me in the chat, if I confused you or if you got it. Let me know as well because I'm going to go ahead and head over there to chat with you. And before I go, just want to remind you, if you have just joined us and you missed this information, hey, if you want to win an AMCI lecture series, you have the chance to win this. So here's how to enter. You need to comment on the video below and tell us what you learned in today's presentation. Or you can also sign up on the link provided in the live chat after the lecture. And hey, we're going to announce that winner next week. That is so exciting. I love this one. So good luck to all of you coders. All right, it's time for me to turn you back over to Mrs. J. Whenever you're ready, Mrs. J.
Hey, hey, I am. Just share the screen and I'm ready to roll.
All right, coming right up.
Great job, Ms. Rochelle. Excellent explanations and coders. I hope you got it. And just like she said, she'll be in the chat to answer any questions that you might have. All right, so the next subject up for discussion are bronchoscopes. And a bronchoscopy is an endoscopic procedure that allows the doctor to examine the airways. So if you look at this picture right here on the upper left, the doctor will thread an instrument called a bronchoscope through your nose or your mouth. I can't tell where this scope is entering, but you get the picture. and he'll fish it down all the way until it reaches your lungs. The bronchoscope is made of a flexible fiber optic material, and it also has a light source so that the camera can view inside of the lungs. So there you have it. That is a bronchoscope. Now it's time to learn the guidelines associated with coding bronchoscopies. Well, a bronchoscopy code series 31622 through 31661, that's a form of it's a type of endoscope. All right. So we use the same guidelines to code, same guidelines as endoscopy for bronchoscopy. So want you to know that an endoscopy procedure, you're going to have to code appropriate endoscopy of the anatomic site examined. So you're going to code the site. Now, a surgical bronchoscopy always bundles the diagnostic bronchoscopy. Make sure that you know that. And the diagnostic codes 31622 through 31651, and the diagnostic and surgical codes 31660, 31661, these all bundle fluoroscopy. So your bronchoscopy bundles your fluoroscopy. You do not have to code fluoro separately. And when it comes to coding, additionally, for endobronchial ultrasounds, or EBUS, you code that separately. And code 31654, this is a transendoscopic ultrasound. You code that separate too. So don't forget your bundled items in your endoscope, specifically that fluoroscopy. And remember, diagnostic scopes are bundled into the surgical scope. And I think it's time to move on. So let's go. A, 31628, 31633. B, 31622, 31628 with a 59 modifier, 31633. C, 31622, 76002, and D, 31628. A 58-year-old male has bilateral peripheral lung opacities of the lower lobes. Bronchoscopy is performed and no lesions are visualized. Under fluoroscopic guidance, a biopsy forceps is inserted into the area of the opacity of the lower left lobe, and 4 lung biopsies are obtained. The specimens are submitted to pathology. Which procedure codes best describe this encounter? Okay, coders, you have 1.5 minutes. Okay, it looks like our timer worked. Okay, coders, what say you? What is the correct answer? if you said D, outstanding. All right, so let's take a look at our keywords. 58-year-old, bilateral peripheral lung opacities, lower lobes, bronchoscopy, fluoroscopic guidance, biopsy forceps, inserted, lower lobe, 4 lung biopsies, specimens submitted to pathology. All right, so let's see what we have being done. We have a bronchoscopy, but if you look at code 31622, this is the code for bronchoscopy. That is correct. However, this code includes fluoroscopic guidance. Remember I said that? So if it includes fluoroscopic guidance, look at C. See this code right here, 7600. This is a code from the radiation section. We know that because we know it's a 7. So if you look up code 76002, this is the code for fluoroscopy. And because fluoroscopy is bundled, we're not going to code it. So we're going to eliminate C. Next, we have code 31628, and it's saying that it's incorrect. It's incorrect. The code is correct, but it's incorrectly coded with 31622. And the reason is this is the code for biopsies of a single lobe, and this is all correct. However, we are not going to code 31628 with 31622. Do you know why? 2 reasons. First, it's a diagnostic scope. 31622 is the code for a diagnostic scope. 31628, that's a surgical scope, and you do not code a diagnostic scope with the surgical scope. You only code the surgical scope. Also, we're not going to code 31622 with 31628 because 31622 is a separate procedure, meaning that it should be coded by itself. If it is not related to another procedure, then it should not be coded with it. Oh, excuse me. If it is related to another procedure, you can't code it with it. 31622 and 28 are related, so you shouldn't code them together. And that's why B is incorrect. Now that leaves A, 31628, and D, 31628. So A has 31628, and it's also coding for 31633. And the reason why we are not going to code 31633 with 31628 is because this parenthetical guideline says 31628 should be reported only once, regardless of how many transbronchial lung biopsies are performed in a lobe. So it doesn't matter. You can have 100 biopsies in a single lobe, and you're only going to use this one code. We know that because you see this this S in the parentheses. That tells you when you see that S, it means any number of biopsies. And we had 4 biopsies of the lower left lobe, and therefore we're not going to code an additional this add-on code. We don't need to use it. Okay, you would use that if it's an additional or a different lobe. So A is incorrect, and D is our answer, 31628. And if you got that correct, outstanding. Now, some of you might say, hey, we went over the guidelines and you weren't able to jot them down and do this scenario. Well, you know what? You can just view the playback. I would view that playback, write down the guidelines, and then try the scenario again. But practice makes perfect, and it won't hurt to do that. Or if you have your TTT manuals, all of the guidelines are in your TTT manuals. We've documented them for you, and you should just be able to reference your TTT manual whenever you you do your scenario. All right, so if you have any questions about this scenario, go ahead and type it in the chat, and I'm going to join you momentarily. And now it's time for me to hand it over to Ms. Rochelle.
Yes, thank you, Mrs.Jay. That was a great instruction as well. And coders, you are all doing a great job. Fantastic on that scenario. So we are going to now move on, and we are going to be talking about the therapeutic wedge resection. And this is going to be coming from your guidelines from your lungs and pleura, which we're going to be talking more later on. But at this point, we're just going to be focusing on this therapeutic wedge resection, which is a procedure that involves the surgical removal of a small wedge-shaped piece of lung tissue to remove a tumor or to diagnose a lung cancer. So as you can see here in the diagram, you can see that cancer over there, and that basically the surgeon would resect a part of your lung so that they can either take it out for biopsy and for treatment purposes. Okay. So as far as coding goes, oh, I do have to show you this too. So what you can see here in your on your screen, you also have another visual of a wedge resection, and another thing that you might wanna know is that wedge resection may be performed as an alternative to a lobectomy. So usually before the surgeon would decide to go on lobectomy, sometimes they would go on a minimally invasive procedure first, and wedge resection, that's when they're gonna take a piece, like I said, a piece of your lung, and then they were gonna either like I said, diagnose it, use that piece of lung to send it to pathology to diagnose, and then decide where they would go from there. Sometimes that would lead to a lobectomy or pneumonectomy, but sometimes that wedge resection is just all they need. So I think I like this visual. So hopefully you appreciate this one too. So let's go ahead and talk about the guidelines here. Like I said, this guideline is part of your lungs and pleura section, and you will find it on page CPT page 198. And this part here is actually under the last column, the second column on your right, the last paragraph. So we're just going to talk about the therapeutic wedge. The rest of it, I think Miss Tracy is going to talk to you about that. Okay. So if you are with me, let's talk about this guideline here. So it's telling us here the things that we need to pay attention to. I'm just going to read it to you. Okay, so a therapeutic wedge resection requires attention to margins and complete resection even when the wedge resection is ultimately followed by a more extensive resection. So what you're going to be paying attention to is that usually a therapeutic wedge resection is going to be bundled into a more extensive procedure. Now, there are other cases where you really have to pay attention to also, because it's telling us here that in case of a wedge resection in which intraoperative pathology consultation determines that a more extensive resection is required in the same anatomic location, like I mentioned earlier, example would be a lobectomy maybe if they decide to do a more extensive resection. When that happens, it becomes classified as a diagnostic wedge resection. So when that happens, your code you're going to be looking at is this 32507 for a thoracotomy procedure, an open procedure. And if you're happen to be coding for a scope procedure, your code would be 32668. But what I want to drive your attention to here is that this code is you will find it as an add-on code, and this reads as thoracotomy with diagnostic wedge resection followed by anatomic lung resection. So you will use this code whenever they have an intraoperative pathology consultation and the surgeon decides to go on and proceed to a more extensive resection. Okay, so that's going to be what you'll be looking at 32507 or 32668 if you happen to be coding for scope. Okay, so let's put in our eyes there. And there's more, okay? So another thing that we have to pay attention to also is that when no more extensive resection is required, remember we're going back to this therapeutic wedge resection, when there's no more extensive resection is required, the same procedure is going to be coded as your wedge resection or the therapeutic wedge resection, and this is going to be your code. Meaning to say that if they did a therapeutic wedge resection and they stopped there, they didn't go for further as having an operative pathology or a more extensive resection, then you will just have to code it as thoracotomy with therapeutic wedge resection. Or if you're going to be coding it as scope, you will have another family of codes that too you will find that at 32666. Okay, so hopefully you understand that. And there's more here as well. When a therapeutic wedge resection 32505, 32506, 32666, or 32667 is performed in a different lobe than the more extensive lung resection, example lobectomy. So in case we're in, there's two lobes of procedures involved, one of them went on and decided to go on a more extensive procedure. However, the other lobe is, only a therapeutic wedge resection was done. Then it's telling us here that you are going to have to code it as therapeutic wedge resection, which would be this code. However, you're going to have to add a modifier 58 with that. Okay. So go ahead if you need a screenshot on this one to review later on. And I think I have another here. I think we're going to make it a little bit easier for you guys to understand. So we simplified the guideline for you. Oh, here. So basically what this is, so with our notations, so this here, this part of it, we already went through it, but just pay attention to this. This just means that these therapeutic wedge procedures are bundled into a more extensive procedure unless it's a different lobe. Okay, that's one thing you have to pay attention to. And another thing is that when a diagnostic wedge resection is followed by a more extensive procedure, so that's what you really need to pay attention to, you will then report the wedge resection add-on code, that diagnostic one. Okay? And then use modifier 59 to report therapeutic wedge with a more extensive lung resection procedure. And that's it. So what do you say, coders? Do you want to try a scenario? This one is a little bit, I would say a little bit challenging, but I know for sure you're going to get this one. So let's go ahead and try it. Let me read to you our answers first. We have A, 32480, 32505 with modifier 59, 32507 with modifier 59. For B, you have 32482, 32505 with modifier 59, 32506. And then C, we have 32480, and D, we have 32505, 32506. Your scenario is we have a patient with a long history of cigarette smoking was diagnosed with nodules on the two lobes of the left lung. The physician performed a thoracotomy wedge resection in both lesions. The specimens were sent to pathology and the results were carcinoma of the lower left lobe. The physician performed a lobectomy on the lower left lobe. Which procedures best describes the encounter? And I'm going to put myself on mute and so I can get started with the timer. So you know the drill. You'll have a minute and a half and then put your answers in the chat. Good luck, coders. You can do this. All right. I think that worked, coders. That is a minute and a half. So get your answers in. And then we are going to talk about the scenario. So let me go ahead and reveal the answer. If you said A, you would be correct. Now, if you miss it, hopefully I'll be able to explain this to you and we're going to learn something from this, okay? So let's go over first our keywords. So we have long history of cigarette smoking, nodules, 2 lobes of the left lung. We have thoracotomy wedge resection there on both lesions. We have specimens were sent to pathology and the results were carcinoma of the lower left lobe. And then the physician performed a lobectomy on the lower left lobe. So I have a diagram here. Just I think I for one really helps me to have a good visuals of what's going on. So pardon me, I'm just gonna try and show this to you. Um, so basically what happened here is that this patient has a you know nodules, okay, on the lungs in 2 lobes of the left lung. So this is your left lung, so imagine that's the nodules there, and this actually the patient is here for that thoracotomy wedge resection of both lesions. So we're gonna just go ahead and imagine there that the thoracotomy wedge resection was done on both lobes because it's mentioned here on both lesions and 2 lobes, right? Okay, so that first lobe here, we know for sure that the thoracotomy therapeutic wedge resection happened, okay? Also, another on the second lobe because it mentioned 2 lobes there. Okay, so everybody following along. So this here on that first lobe, just imagine that we actually just stopped there. So the physician only did the thoracotomy, therapeutic wedge resection there. However, on that second lobe, specifically the lower left lobe. See here, if you read this highlighted keywords here, specimens were sent to pathology and results were carcinoma of the lower left lobe. And that lower left lobe, the physician actually performed a lobectomy on the lower left lobe. So they decided to proceeded on doing a lobectomy on this lower left lobe there. Now, remember the guidelines that we talked to you about earlier in your CPT manual regarding the therapeutic wedge procedure. The first thing, therapeutic wedge procedures are bundled into a more extensive procedure unless it's a different lobe. Now, let's talk about this first here. The first lobe. So this therapeutic wedge resection is a different lobe than the extensive procedure on this second lobe over here, right? So that means that we're going to have to code this therapeutic wedge resection. And because there was a lobectomy happened on that second lobe, we are also going to follow this guideline here. When a diagnostic wedge resection is followed by a more extensive procedure, in our case, that lobectomy is indeed the more extensive procedure after the diagnostic wedge resection. Okay, so we are going to have to report the wedge resection as an add-on code, which we will find as the 32507 code, which I'm going to show you in the next screen. So basically, this is what we're going to be looking at. Oops, sorry. I'm going to actually go back in case you want to go ahead and take a closer look at this. So we're going to code our thoracotomy wedge resection for that first lobe, and we're going to code a thoracotomy, but in this case we're going to have to code it as diagnostic thoracotomy diagnostic wedge resection, because this second lobe proceeded into a more extensive procedure, which would be the lobectomy. And then of course we're going to code that lobectomy. So if we're going to take a look at this and code this all together, let's go ahead first and eliminate what we don't need. So we have 4 answer choices here. We will find that 32505, that is your code for the thoracotomy with therapeutic wedge resection. That's your initial. So we need this code, right, for that first lobe. Remember, we only went as far as therapeutic wedge procedures, but this is the different lobe. So we definitely need this wedge resection for that first lobe. Okay, and we also need to code for that add-on code 32507 because the second lobe has turned into a diagnostic wedge resection followed by anatomic lung resection, which would be, remember that, lobectomy. Okay, so we need both codes. So as far as here, if you look at D, this is missing the lobectomy, so this is wrong here. Answer C as well. 32480, that's only coding for lobectomy, which we're going to look at, but this is missing a lot of things. Okay, so we're going to go ahead. Sorry about that, my own clicks are off, but we need to eliminate C, and then I'm going to drive your attention to this. Okay, so we also have to code again. We have your thoracotomy, we have your diagnostic wedge resection, and of course we have to code for that lobectomy, of course. 32480, removal of lung other than pneumonectomy, single lobe. If you look at B there, though, it's coding for the 2 lobes. Okay. Oh, actually, that box should be here. The 32482 here is 2 lobes. By lobectomy, we only get to code 1. The lobectomy only happened in the lower left lobe, which would mean that B is going to be eliminated. So if we're gonna look it up together, of course, we're gonna code first the lobectomy. That did happen. We're going to code 32505 with modifier 59 following the guideline to indicate the therapeutic wedge resection of that, the first lobe out of the 2 lobes. And again, following the diagnostic wedge resection guideline, that second lobe did turn out into a diagnostic therapeutic wedge resection because after that wedge resection, they did proceed into a more anatomic or diagnostic wedge resection followed by anatomic lung resection to be exact. And that anatomic lung resection would be your lobectomy. So you do need to code that with modifier 59, and that completes your procedure that describes this encounter. So hopefully you were able to make sense out of that. And if not, I'll be happy to answer your questions in the chat. Please do. I encourage you to ask questions. And I think that's it for me. So what do you say, Mrs. J?
I say, hey, that
Thank
was
you.
extraordinary. Excellent job, Ms. Rochelle. Excellent job. Like she said, she's going to be in the chat. Some of you may have some questions, but my advice is to, after this viewing, this will go into playback form. So you can just go ahead and watch it again and do it very slowly, do it at your own pace, because that was a great one. Thank you, Ms. Rochelle. All right. Okay, it's not my turn. Let me just double
I'm
check.
over here talking away. It is
I
me.
know it's your turn. That's Mrs. Tracy's turn. Go ahead, take it away, Mrs. Tracy.
Okay, thank you. I'm talking away and nobody can hear me. Sorry about that. Okay, everyone. So we are going to talk about lung biopsies, and in this, the guidelines that I'm going to talk to you about here, Miss Rochelle covered a lot of it. So we're just going to kind of review some of that and introduce a couple more things. Okay, so lung biopsies can be open. They can be um, through thoracoscopic or VATS, and we're going to talk about that more in detail. If you know what VATS is, before I talk about it, go ahead and type it in the chat. I want to know if you know VATS, V-A-T-S, okay? That's the challenge question. All right, and they could be thoracotomy too, so cutting into the chest, okay? So through a scope, they could be cutting into with an incision, or percutaneous. All right, so let's go ahead. One thing that I want to say is a big guideline to remember here: our diagnostic biopsies are bundled into major procedures, such as segmentectomies, lobectomies, and thoracoscopic VATS lobectomies, okay? And Miss Rochelle just went over the wedge resection with you all, and the exception to that. And so we're going to go ahead and talk about this more in detail. Okay. All right. So you can find this actually on page 198 in your 2019 CPT manual. Okay, so just at the top, it's telling you pleural cavity or lung biopsy procedures may be accomplished using a percutaneous, thoracoscopic, video assisted thoracoscopic surgery. There's the VAT. So did you guys get it? So your VATS again, that is video assisted thoracoscopic surgery. Okay, so that is a scope with a video camera at the end of it to help guide the surgeon into what he's looking for and what he's looking at. Okay, or they could be a thoracotomy approach. Okay. All right, so here's what is bundled. Lung resection procedures include diagnostic and therapeutic procedures, including the removal of blebs, bullae, cysts, and benign or malignant tumors or lesions. Okay, this is what you need to watch out for. And Mrs. Rochelle just went over all of this with you, okay, the wedge resection. So this takes up a pretty good part of these guidelines here. So just know when you're coding for wedge resections, and I think Mrs. Rochelle did a wonderful job explaining this. So just watch out for those guidelines that Miss Rochelle went over with you guys regarding the therapeutic wedge resection. All right, so turning our attention over to the right column over here. Basically, this is just telling you these are some guidelines to watch out for too. So when diagnostic biopsy or biopsies of the lungs are performed, regardless of the approach that's done, whether it be open or VATS, then the specimen is sent to intraoperative pathology consultation, and during that session, the surgeon uses those results to determine the extent of the necessary surgical resection that will require. Only the most extensive procedures performed. Okay, so to sum it up, basically that diagnostic biopsy is going to be considered bundled, okay, into the more extensive procedure. Alrighty. And then also, Ms. Rochelle went over this as well with you. So this is talking again, this does talk a lot about your wedge resection. So when you're coding for wedge resections, just pay attention. So the therapeutic wedge resection codes 32505, 32506, and 32666 or 32667 if you're dealing with through the scope endoscopic or scopes should not be reported in addition to the more extensive lung procedures such as a lobectomy, unless the therapeutic wedge resection was performed on a different lobe or on the contralateral lung, okay? And this is talking about therapeutic wedge resections, okay? And Ms. Rochelle went over if it is what they consider a diagnostic wedge resection. So as in that last scenario, you were going to code it because it was considered a diagnostic wedge resection, okay? So, and that part of it is down there in the guideline, okay? So then you could report the add-on code either 32507 or 32668 with the more extensive procedure if it is a diagnostic wedge resection, okay? So pay attention whether it's diagnostic wedge resection or therapeutic wedge resection. All right, and again, that modifier, if it is performed, the therapeutic is performed on a different lobe than the more extensive lung procedure, then you use a modifier 59, okay? All right, so moving right along, and I do want to talk a little bit, I want to show you the codes for VATS and talk a little bit about VATS, okay? Just in case you're not too familiar with this, but your VATS is your surgical thoracoscopy, okay, or thoracoscopy. That word always throws me off. Thoracoscopy. So this is video assisted thoracoscopic surgery, and this is basically just a minimally invasive surgical technique used to diagnose and treat problems in the patient's chest. And during this procedure, a tiny camera, or they call it a thoracoscope, and surgical instruments are inserted into the chest through these little small incisions in the chest wall. And that thoracoscope transmits images of the inside of the chest onto a video monitor, and that just helps guide the surgeon in performing whatever procedure he's performing, okay? And those video assisted, the VAT surgery, that technique is used to perform a variety of operations. It could be biopsies to diagnose lung cancer or other chest cancers. It could be lung surgery to treat lung cancer. And even other things such as like those hernia repairs and things like that can also be done through that, okay? And again, if you notice here on this page, um, it tells you again, very important, surgical thoracoscopy always includes diagnostic thoracoscopy. So look at that 32601. That's your diagnostic code. Okay, so that is the and you might just want to put out. We always do this, and this is very helpful. On this code, you might just want to put DX right there at that code level, just to let yourself know this is your diagnostic procedure. Now, if a surgical procedure is performed during this diagnostic procedure, it would be that diagnostic code or procedure is bundled into your surgery, meaning you don't code it separate. Good indicator of that, it says separate procedure right there, okay? So when this is not related to the more extensive procedure, you can code it separately. However, if it is related to the more extensive procedure, it gets bundled, okay? So again, next to 32601, you might just want to say this is your diagnostic code. Everything below that shares the same parent language. However, those are for your surgeries, okay? Biopsies and so forth, okay? All right. And that's your code range, 32601 to 32665. Okay, so I have a scenario for you, and here's our answers. A, 32607, B, 32671, 32607 modifier 59, C, 32671, D, 32440. A 59-year-old retired bus driver diagnosed with lung cancer of the lower right lobe undergoes an incisional lung biopsy. The patient is prepped, draped, and placed in supine position. After anesthesia induction, the surgeon makes a small incision and inserts the thoracoscope with camera to view the lung area. An additional incision is made for insertion of procedural instruments. After viewing the area, the physician decides to perform an excision. He advises the anesthesiologist to deflate the right lung in preparation of the removal. The lung is removed and the small incisions were closed. Which procedure, code, or codes best describe this encounter? And you have a minute and a half, and your time begins now. All right, type me in the chat. Tell me how you did. Okay, so let's go ahead and walk through this one. Okay, so looking at my answers here, not really telling me a whole lot. I do see that 32607 is listed in both answer A and B. I see a modifier 59 there, and I see all the codes are pretty close together. B and C have the same first listed. So let's go ahead and look at this. Okay, our answer is C. Let's find out why. Okay, so my keywords, we have 59-year-old, lung cancer, lower right lobe, incisional lung biopsy, incision, thoracoscope with camera, excision, right lung, removal, lung is removed. Okay, so first of all, let's look at 32440. That's in answer D there. That is for removal of a lung. So yes, I do see the lung is removed here. However, that is going to be for an open procedure there, and we have, in our scenario, this is done through the thoracoscope, okay? So we're going to have a thoracoscopy procedure here and not just the open procedure right there. So that 32440, that's what that's coding for. So that is going to be wrong procedure, okay? Or wrong approach. All right, so we are going to move on to 32607. I see that answer in A and also in B, and that is a thoracoscopy procedure. I like that. With diagnostic biopsies, it does say that there's a biopsy, an incisional biopsy here. This 32607 does cover the incisional biopsy. However, there is a more extensive procedure that is performed there, okay? So we are going to just code for the more extensive procedure according to our guidelines, right? So that would make 32607 incorrect. And why is B incorrect? Let's look. If we look down at our parenthetical guidelines, first it tells us do not report 32607 more than once per lung. And then it also says some do nots there. Oops. Okay, there's some do nots, okay? Do not report 32607 in conjunction with 32440, 32442, 32445, 32448, and 32671. There's our 32671 that's coded together with 32607 in answer B, okay? Because that 32671 is the more extensive procedure. Our parenthetical guidelines telling us do not code this diagnostic biopsy with the more extensive, okay? So that's basically what that guideline's telling you. So we can go ahead and get rid of answer B. Remember, that's a guideline. We always got to follow what it's telling us, okay? So immediately that's wrong. And that's why it's important to always read those parenthetical guidelines. Okay, so moving on, let's see 32671. If we read at the parent level, that's for a surgical thoracoscopy and with removal of lung, okay? And that's what happened here. We had a thoracoscopy procedure with the removal of the lung, okay? So we're just gonna code 32671, and that's it. All right. Everybody see that? If you got it correct, great job. If you see your mistake, that's even better. So as long as you're learning through this process, that's really, truly what matters. So I think you guys are doing an amazing job, and I think I'm going to go ahead and pass this over to Mrs.Jay. I think. Give me a second.
You
Okay.
are absolutely correct. If you can, that would be amazing. Great job, Mrs. Tracy. All right, so coders, Mrs. Tracy said that she will, I don't know if she said it, but if she did or did not, she's going to be in that chat. If you have questions about that VATS scenario, go ahead and ask away. Was that the VATS that we were talking about? Well, she did too. No, Miss Rochelle did the VATS, and Miss Tracy talked about the biopsy. And now it's my turn to speak to you about lung transplantations. So we pretty much know what a lung transplantation is. But let me review really quickly. It is a surgical procedure in which the patient's diseased lungs are partially or totally replaced by lungs that come from a donor. Now, when a lung transplantation takes place, the entire lung is replaced by a donor lung. And is that donor lung is harvested from a cadaver. A living person does not donate a lung. While they can donate a lobe, they will not donate a lung. Therefore, a living person would not be coding from this section. So a living harvest would not. So let's just quickly review our lung. On the left, right here, this is a lobectomy because a lobectomy is removal of a lobe. A pneumonectomy is the total removal of the lung. All right, so hopefully I didn't digress too much, but if you look on page 204, you'll find your guidelines for lung transplantation. And there are 3 distinct procedures that you'll be coding for. Number 1, did cadaver donor pneumonectomies, did they take place? So did they harvest the lungs from the cadaver? If so, this is what you'll be coding. Was backbench work carried out? Typically, they'll have to prepare the cadaver donor, and that's called backbench work. If it was carried out, you're going to use 32855. And finally, did the recipient lung allotransplantation take place? If so, you're going to use codes 32851 through 23854. Now, with that said, I think we're ready for our first scenario. A, 32850, B, 32440, C, 32486, and D, 32442. A 70-year-old female with lung cancer and a long history of tobacco use. Okay, one second. I have what do you call I have something blocking my screen, so had to move it out of the way. Sorry about that. So, a 70-year-old female with lung cancer and a long history of tobacco dependence presents today for a left sleeve pneumonectomy. The patient is a candidate for a lung transplant. Patient and surgeon are hopeful for a near future procedure. The patient is prepped, draped, and appropriately anesthetized and placed in supine position. Thoracotomy is carried out. A rib spreader is used to separate the ribs for better lung accessibility. Bronchotracheal anastomosis is achieved by dissecting the hilum and esophagus, then retracting the esophagus. The tubular section of the trachea is removed, then reconstructed. This is performed to reroute air passage post-pneumonectomy. After successful anastomosis, the left lung is excised. The surgeon confirms the newly constructed air passages are flowing properly with no obstructions, then wires the rib cage halves back together and closes the incision with staples. Which procedure codes best describe this encounter? Okay, coders, I'm going to give you a minute and a half. All right, so I gave you a little extra time and I'm ready to solve this scenario. Okay, coders, what say you? If you said D, outstanding. Now let's go ahead and solve our keywords. 70-year-old, lung cancer, long history tobacco dependence, left sleeve pneumonectomy, thoracotomy, bronchial tracheal anastomosis, trachea removed, then reconstructed, pneumonectomy. After anastomosis, left lung is excised. All right, coders, it's saying that 32850 is incorrect. It's incorrect because this is the code for donor pneumonectomy. And we are not coding for a donor pneumonectomy. We're not coding for a cadaver or deceased person. We're coding for the patient's pneumonectomy. See, this is a 70-year-old patient that's having a lung removed. All right, so we're going to go ahead and eliminate A. Next, 32486. This is the code for removal of lung other than pneumonectomy with circumferential resection of segment of bronchus, followed by bronchobronchial anastomosis or sleeve lobectomy. That is entirely the wrong procedure. We had a sleeve pneumonectomy, and this is coding for a procedure that's other than a pneumonectomy. This is coding for a lobectomy. So we're going to eliminate C, 32486. And finally, we're at 32440. This is the code, or the parent code for a removal of lung pneumonectomy. That is indeed what happened. However, if you go down to 32442, this code codes for the pneumonectomy and for the resection of a segment of the trachea, followed by a bronchotracheal anastomosis or a sleeve pneumonectomy. And that's what we had, a sleeve pneumonectomy. So we like 3224. We're going to eliminate 32440. And our answer is D. Okay, coders, how do you feel? All right, so if you got it correct, outstanding. If you learned something, you know what, that's better because it's priceless. Okay, so I think I'm finished and it's time for me to hand it over. Let's see who's up next. Is that you, Miss Rochelle?
It's gonna be me, Mrs.Jay. Thank you so much.
You are
That was a
welcome.
Yeah, thank you. That was a great scenario. And I think coders, what do you say? I think we have a few time more, time to do some challenge scenarios. So let us know in the chat because we do have some great scenarios for you, some more. So let's go ahead and get started, shall we? So let me bring up my challenge scenario here. Here we go. We have A 31231 with modifier 50, 30115 with modifier 59, B 30110, C 30115, D 30110 with modifier 50, and 31231 with modifiers 50 and modifier 59. A 50-year-old police officer who had a history of cocaine use but has been clean for over 10 years presents to the doctor's office for random episodes of nosebleeds, particularly when he blows his nose. The physician decides to perform a bilateral nasal endoscopy. The patient is prepped, draped, and anesthetized, and a flexible endoscopy is inserted into the nasal cavity. He examines the nasopharynx and observes two nasal polyps in the left cavity. The scope is removed. The physician inserts biting forceps through the left nostril and removes both polyps. He packs the nasal cavity to control bleeding. Which procedure codes best describes this encounter? All right, coders, this is your challenge question. Let me go ahead and put on my handy dandy timer, the fancy one, and your time starts now. All right, coders, I believe that is time. Get your answers in the chat. And if you said the answer is B, then you would be correct. That's great coding. So that, how did we arrive to the answer? So let's go ahead and take a look at our keywords. We have 50-year-old, office, nosebleeds. We have bilateral nasal endoscopy. We have flexible endoscopy inserted. We have nasal cavity, two nasal polyps in the left cavity. Scope is removed. Physician inserts a biting forceps, left nostril, removes polyps, and that's it. So I'm actually going to drive your attention to this code 31231, because as you can see, you will find that code on your answer choices A and D. Okay, so if you look at that description there, that is coding for your nasal endoscopy, diagnostic, unilateral, bilateral, separate procedure. Okay, hopefully you catch that, because this nasal endoscopy is a diagnostic procedure. And remember our guideline, diagnostic scopes are going to be bundled into the surgical scope, which in our scenario here, that surgical scope would have to be that removal of the polyps. And another thing, remember that this is a separate procedure as well. Okay, so with that being said, we can now eliminate answers A and answer D, because we do not need to code that diagnostics procedure. All right, so now that we eliminated both A and D, we can now take a look at answers B and C. And you will find it here. 30110 is your excision, nasal polyp, and polyps, with that S there, emphasizing that. One is for simple, and simple here is actually defined in your parenthetical guideline. 30110 would normally be completed in an office setting. So thankfully, we had that in our keywords. We highlighted that as well. So now we know that this is the right code for us, because if you look at 30115, that is your excision, nasal polyp or polyps as well. This is extensive. And it's also being defined here in your parenthetical guidelines as 30115 would normally require the facilities available in the hospital setting. Again, remember we highlighted in your keywords, and that's the significance of doing so. We know that this was done in the doctor's office. So out of these two, we are going to be coding this, we are going to be coding this as a simple procedure, which would be the 30110. Okay? So hopefully you got that. I think you all rock this scenario. So if you have questions for me, go ahead and type them in the chat. But I do know that Miss Tracy has some more scenarios for you guys.
Yes, I do. Great scenario, Mrs. Rochelle. Great job, coders. And yes, we are starting to wind down. I have a couple more challenge scenarios for you all. So let's get started, shall we? Okay, our answers here, we have A, 31575, K21.9, B, 31575, 31231, modifier 59, K21.9, J38.7, C, 31579, J31.2, J38.7, K21.9, or D, 31575, J31.2, J38.7, and K21.9. So as you notice, we have some ICD-10 codes there, so grab that one, that manual as well if you have it. All right, here's our scenario. A 43-year-old female with complaints of feeling something is in my throat with a history of gastroesophageal reflux and chronic sore throat arrives to the ENT for diagnosis. Flexible laryngoscopy was performed after the nose was anesthetized with topical tetracaine and oxymetazoline to evaluate for vocal fold lesions, closure, and swallowing function. Pertinent findings include nasopharynx, clear, hypopharynx, no masses or abnormalities with post-cricoid edema, larynx, vocal folds are mobile with abduction and adduction with bilateral vocal fold edema, some collapsed lateral pharyngeal walls at NP/OP level of Mueller maneuver, complications none, condition was stable. I am confident the sore throat pain is caused by the patient's GERD. Patient tolerated the procedure well. Which procedure and diagnosis code or codes best describe this encounter? And you have a minute and a half, and your time begins now. Good luck, coders. All right, everybody, how'd you do? Let me know in the chat. Okay, so looking at our answers here, I noticed that we have 3 of the same answers. First listed codes here, we have 31575 in A, B, and D, and then C is not too far away either, so we're going to read forensically there. We do have an additional code of 31231, and then we have some ICD-10 codes, okay? So let's see what our keywords are. First, let's reveal the answer. Our answer is going to be A. Let's find out why. Okay, our keywords, we have 43-year-old female, history of gastroesophageal reflux, chronic sore throat, diagnosis, flexible laryngoscopy, and GERD. Okay, so not too many there. So let's go ahead and see what that 31575 is all about. So that's our code for the flexible laryngoscopy. Okay, that was done. That exact procedure was done there, and this was for a diagnostic laryngoscopy. Okay, so I like that code. And if we look at 31579, that is also for a flexible laryngoscopy or rigid telescopic with stroboscopy. Okay, I don't see anything in my scenario mentioning a stroboscopy. Okay, so if it wasn't mentioned, we can't code it. Okay, code what we see, not what we think. So we're going to go ahead and get rid of answer C. Okay, so that's gone. Next, sorry about that. The next thing I want to look at is there is some parenthetical guidelines right here under code 31575. And the first one there says do not report 31575 in conjunction with 31231 unless performed for a separate condition using a separate endoscope. Okay, that didn't happen here. There wasn't a separate condition using a separate endoscope. So if I look down at answer B, 31231 is being coded with 31575, and per our parenthetical guideline there, or PG note, it is, that guideline tells us not to code those together. So that means B is going to be automatically incorrect, okay? And then there's another do not here, doesn't apply in this situation, but we always want to just make sure that we're paying attention to those parenthetical guidelines, okay? And then now it comes down to, we know 31575 is our procedure code. Now we have to code, I always call this the tiebreaker. So we have to go to ICD-10 to break this tie here to figure out what our code is, what our answer is going to be. So I noticed that in A, we are only coding K2 1.9. It also codes that in D. And in D, it's coding some additional J codes, okay? So let's see what those are. Okay, J3 1.2 is for that chronic pharyngitis, which is basically for that sore throat, okay, that chronic sore throat. And this is going to be, that sore throat is actually an integral part of the GERD. And the physician is even saying, I'm confident the sore throat is caused by the patient's GERD. And so anything that's integral to that diagnosis would not be coded separately. Okay, that's a guideline within ICD-10. So therefore, this chronic sore throat that we see there in J31.2 is going to be incorrect. And also J38.7 says other diseases of the larynx, and it lists some things such as abscess of the larynx, cellulitis, disease, necrosis, any of that stuff, that is not applicable to our situation. So that is also going to be incorrect. Okay, so we can get rid of D, and then K21 is simply just coding for the GERD, okay, the gastroesophageal reflux disease without esophagitis, because it doesn't say the patient had esophagitis. So we are going to code it without, and that would make A the correct answer. Okay. All right. Give you just a few seconds. If you want to, I don't know if you're taking a snapshot of this or you want to review it later, but go right ahead. Feel free to do so if you'd like, or you can just always simply just watch the playback. Okay, so I'm going to go ahead and move right along. I have one more scenario for you, and here's our answers. We have A, 30520, 31255, modifier 51, B, 31254, 30520, modifier 51, C, 30630, 31254, modifier 51, or D, 31255. An 18-year-old high school football player has a deviated nasal septum after severely breaking his nose. He arrives today for submucous resection and endoscopic ethmoidectomy. The patient is prepped, draped, and placed in supine position. After induction of general anesthesia, a flexible endoscope is inserted into the nasal cavity. The scope is placed into the anterior portion of the nasal cavity. The ethmoid bulla is identified and removed. The scope is moved to the posterior ethmoid. The area is opened, the bony partition is removed, and all loose particles are removed. The scope is removed from the nasal cavity. Then the surgeon makes a Killian incision. The cartilaginous and bony septum is exposed, and the mucosal flap is elevated. Irregular bones are removed below the mucosa. The flaps are then returned to normal position. the incision is closed with sutures, and a nasal splint is applied. Which procedure, code or codes, best describe this encounter? And you have a minute and a half. Good luck. Your time begins now. Alrighty, everyone get your answers in the chat, please. Okay, and let's go ahead and look at this one. I always like, I always like to look at these answers. I see some modifier 51 here. I also see this 31254 listed in B and C. And I see 31255 listed in D and A. So anyways, let's go ahead and take a peek at the answer. Our answer is going to be A, okay? And our keywords are 18-year-old deviated nasal septum. He severely broke his nose, submucous resection, endoscopic ethmoidectomy, general anesthesia, flexible endoscope, inserted nasal cavity, scope anterior portion, nasal cavity, ethmoid vola removed, scope posterior ethmoid, bony partition removed, and loose particles removed. Scope is removed, and then a Killian incision is done for the bony septum, and irregular bones are removed below the mucosa. All right, so it looks like a couple things are going on here. So first of all, let's look at this endoscopic, I apologize for that, ethmoidectomy, okay? And first, I see 31254, and I want to look at that code because I see it in answer B and I see it in answer C, okay? So if we look at 31254, this is definitely coding for nasal sinus endoscopy, surgical with ethmoidectomy. So that all looks good. It says for partial, this is for partial, so this would just be the anterior portion, okay? I do see the anterior portion was done here. However, it also says posterior, okay? So this 31254 is only coding for part of what was done, okay? We have to code for the anterior and the posterior, okay? So let's go ahead and look at So we're going to code for anterior and posterior, and we have a code for that, okay? If you look down at 31255, so we wouldn't code this 31254 because the 31255 is going to include the anterior as well as the posterior, okay? So that's higher specificity there. So we're going to go ahead and get rid of B and C, okay? Everybody see that? Okay, so we only need one code. So for that portion of it, for the nasal sinus endoscopy with the ethmoidectomy, we're going to code total anterior and posterior. Okay, according to our scenario. Okay, so that 31255 is in answer D. It's also in answer A. However, in answer A, we have one more code that we're dealing with there, and that is 30520. Let's look at what that is. And that is for the septoplasty or submucous resection, okay? That was also done here. Your submucous resection was also done, okay? So we're gonna go ahead and, whoops, sorry about that. Okay, so we're gonna go ahead and we're gonna code that as well because it says down below that an incision was made and then that procedure was performed. We're gonna code that first as it'd be the more extensive procedure. Okay, anytime an incision is made, that's gonna be your more complex, and then anything that's done through a scope would be coded in addition. Okay, so we're gonna get rid of answer D, and A is going to be the correct answer. And of course, we'll append a modifier 51 just to indicate that multiple procedures were performed. Okay. Alrighty. So how'd you guys do? That is the end of our class. However, I do have one more thing that I do want to go on and show you guys just for extra practice. Before I hand it back on over to Mrs.Jay, go ahead and if you'd like to take a screenshot or a snapshot or whatever you want to do of this before I reveal the answers, go for it. I'll give you just about 5 seconds. Give you some nice practice. Test your skills in this section. And I'm going to go ahead and reveal the answers now. Okay. And that's it. Mrs.Jay, what do you say? I think they did an amazing job today.
I agree. I'm going to say hey because it rhymes. Anyway, just keep it on your screen and let's just kind of end this and show them what they can do. If you want to go ahead and practice some more in the respiratory section, the principles of CPT, they've listed some great internet-based exercises. So go ahead when you get the playback, just screenshot it, get these addresses, and boop. And next week, we will be discussing the cardiovascular system. Boop. Okay, so I'm in a playful mood. Yes. And since I'm in a playful mood, I want you to play too. I want you to win. Here is the way to join our raffle, which will be next week. And if you win, you will win an AMCI lecture series. Just comment below, not in the chat section below, and tell us what you've learned today. Yes. And then we will send you a sign up link. You know what? The sign up link is in the chat. Go ahead and grab it. And we're going to announce the winner next week. All right. I think that's it. Mrs. Tracy?
All right, awesome. And if you guys have any other questions, you can just go ahead and contact our customer service department, or you can visit our website at, you see the website address here, or we like to say amcicoding.com, lead you right to the same place. So you can either reach us at www.amcicoding.com or www.absolutecodinginstitute.com, takes you to the exact same place, or you can find us on Facebook, Absolute Medical Coding LLC. Come in and join our page. We'd love to have you in there. And let's see, next week we will be going over cardio. So I know that is an area that even I need extra study on. So I will make sure that I am here with you all as well. So thank you all for coming in today. Great class, Mrs.Jay, Miss Rochelle, and thank you, coders.
Yes. Thank you, Mrs. Tracy. Coders, go ahead back in that chat if you have questions. I'm going back in and I'll be answering. Thanks again, Mrs. Tracy, Ms. Rochelle, and we will see you next week. That's week 4. Take care.
Bye, everyone. Have a wonderful day.
Bye. See you next week. Bye.